Morning, everybody. Since there is, yeah, this is forward. Thank you. Since there's nobody to introduce me, I'm Dr. Lakshmivas, erstwhile pediatric anesthetist, presently practicing chronic pain management in my own clinic. Today I'm going to speak about how to place the plexus catheters precisely. I have not considered it only as a plexus catheter, but also any peripheral perineural catheter. Precision is all about how much anatomy is there in the operator's head. It is all about anatomy, and variations of anatomy. All the other aids like ultrasound, peripheral nerve stimulator, etc. are only aids to this anatomical knowledge. And accurate placement of a cannula does not ensure that you will have an accurate catheter placement. So, what type of catheters do we have? Simple epidural catheters which can be placed through a stimulating cannula, or we use ultrasound guidance. This is an anatomical placement close to where a nerve which is supposed to supply an area is located. But then nature has a lot of variations. And so many times when you place near a particular nerve which you think is supposed to supply somewhere, it may be supplying a little bit more elsewhere also. So ultrasound gives you anatomical guidance, whereas a stimulating catheter with a stimulating needle gives you a function-based placement. It is like what you see is what you get. There are lacunae in this, which I'll come to later. However, you can have the best of both worlds by using the ultrasound for an easy, quick location of the nerve, and then place a stimulating catheter with peripheral nerve stimulation guidance, or as Dr. Su Ganapati said today, with using Doppler and injecting little bits of dextrose to guide you. So, nerve stimulation is used to position the nerve close to the plexus or nerve, and then local anesthetic is injected, and then a catheter is inserted blindly. However, blindly inserted catheters have their own mind. They go as they wish to go and not as you wish them to go. You cannot steer your catheters as you would steer the tip of an endoscope. So it can go any which way that it wants. So you think that you have placed your catheter very well, but your catheter may be elsewhere. So the status of blindly placed catheter has been criticized quite a bit. Then where do these catheters go? So 60 to 70% of the lower limb catheters are not positioned close. Like this lady here, we are locating with the stimulator, and then, where is the, and then as I'm passing the catheter, there is no stimulation. Here, I would like to draw your attention to the video that Dr. Ganapati showed of Dr. Vincent Chan stimulating a nerve in a pig. He was putting a needle into a nerve and he was not getting stimulation. But then when he went close to another nerve, there was stimulation. Well, I cannot claim this here. I have stimulated with a needle, and I expect that nerve is equally sensitive to the catheter too. So I cannot claim that, my catheter is really near the nerve, but it is not stimulating. A nerve which has been stimulated already will continue to be stimulated with a catheter too. So you can also confirm with a fluoroscopy sometimes. This is a catheter which decided to go along the radial nerve. So to bridge all these lacunae, stimulating catheters were devised. The advantages of the stimulating catheter was reduction of local anesthetic, improved motor nerve block, and then AORA came up with this, or now Payung also has this facility, and all the stimulating catheters will have this facility. You can stimulate the catheter long after it has been placed. This is very useful for somebody in chronic pain management like me, where I might want to stimulate the catheter 15 days later. If it is not working, I will know if the movement of the patient has made the catheter migrate. So this is a patient where we are stimulating immediately, and you can see this is a radial stimulation. And this stimulation is being done through the end of the catheter later. So answer for secondary catheter failure is stimulating catheter? Maybe. Nerve location with the needle is quick and easy, especially if you use combined modalities of ultrasound. Ultrasound shows you where you are, but then catheter can be very frustrating. Placing it where you want it to go is almost like it's an autonomous body. Time taken, all these things have made it very difficult to place stimulating catheters. It is not that only stimulating catheters are difficult. All catheter placements, precise placement is difficult. It is just that when you use a non-stimulating catheter, you don't know where it goes. When you use a stimulating catheter, you're confirming to yourself that it is not going where it is supposed to go. So, however, regional anesthesia is meant for surgery. We want a quick block. Not everybody is lucky as Ganga Hospital anesthetists, where surgeons have a lot of patience. It's not really patience. They understand which side of their bread is buttered. And not all surgeons are that smart. Anyway, so problems with placement of stimulating catheters led to analysis and controversies. Why do we really need to do all this exercise? So one very important thing is we usually look at stimulation. We can only confirm motor stimulation. Paresthesia is not really advisable. So we look at a twitch downstream of the nerve that we are stimulating. So what I have been observing is when you're stimulating, you don't see a twitch in the hand, but you can see a twitch in the muscle if you put an ultrasound on the muscle which is supposed to be flexing that finger or extending that finger. So this is a different kind of use of USG to detect the twitches. So like you can get hamstrings twitches appear earlier, long before the foot twitches can be seen. Not all the time, but sometimes. And what stimulating value to accept? I can get stimulation at 2 milliamperes. Is that acceptable? No. There are uncertainties. However, up to 1 milliampere is accepted. Now, here is this patient where I can detect it at 0.5, whereas externally I could not see a twitch up to almost 1.5 milliamperes or more. So this is a slightly off-label use of ultrasound. And then there are also a lot of queries about how reliable is stimulation. You may have excellent stimulation and no block, and no stimulation and an excellent block. And not all nerves are same. You have plexuses, you have a big fat nerve like so, and you have all the varieties. So I won't go into all this because I think a lot of this has been spoken of already by my previous speakers. Now comes ultrasound. The new kid on the block, fantastic tool, because USG is like, if you want to compare non-USG and USG, it's like sitting on a beach and looking at the sea, is what we used to do. And then you gear yourself up and go scuba diving. That is USG for you. So USG has been very, very useful. And then, of course, there were schools of thought. You know, USG is better or PNS is better. But we as clinical anesthetists, we need result, not about who is better or what is better. So combination is a good idea. But however, there are controversies on this also. Some will say, yes, this is good. Some will say you're spending more money. Some will say, you know, why if you're doing both, what is the great idea? This is all splitting hairs. What you want is result. Cost concern, for a catheter, you spend a lot of money. So you spend $40 less if you are not using a stimulating catheter, but you use ultrasound. But then you need to pay a huge capital expenditure for an ultrasound. All said and done, it's about efficacy. What is needed? You can't make omelets without breaking eggs. You need to get what you need to get. So anyway, the advantages are also you're seeing what you're doing. That adds a tremendous amount of safety. These are the conclusions. I'm not finishing here. I'm showing you a few videos. Nerve stimulation of needle with a non-stimulating catheter saves time, but stimulating catheters ensure accurate placement. Accuracy, do you really need that level of accuracy for anesthesia? Bala mentioned plan B. You always have plan B available to you in regional anesthesia. However, as a chronic pain specialist, I do not have that luxury. I need to have accurate placement. So I go more towards stimulating catheters because I like to see what's happening. And many times, we need to know if the patient has pain in the ulnar distribution, I need to go there, as in one of the videos I'll show you. So available stimulating catheters in India, AORA and Payung. Payung is a thinner catheter with a wire inside the catheter, whereas AORA has a wire spiral along the catheter. This is also a thinner needle, 19 gauge needle. This is the catheter tip, and there is a mandarin wire, very fine mandarin wire which you cannot see. AORA catheter looks like this. This is where you can stimulate after you have placed it, and this is where you stimulate when you are passing the catheter. And the wire makes it easier for you to visualize on ultrasound. However, the tip, if you look at it, it's a little bulb. It can snag in tissues and it can create real trouble when you're bringing out. This is how you place it on a needle, the wire, stimulating wire, and then you can place it here for stimulation later, and this is how the catheter looks. And the StatLock fixation device is fantastic, really. So this is the stimulating needle being used, stimulating wire, then attach it here, later stimulate it like this. But then, as I was mentioning with AORA, sometimes it can snag in the tissues and you really have to tug at it. And in one patient, 2 patients I have had this complication. I showed you the first complication, and in another patient, it snagged so much that the plastic wire came out, but not the metal wire, which had to be later taken out. After this, I have decided that it's not worth it, so I usually go for Payung, which has got a wire inside the catheter. Here I want to show you this patient where, to show you, emphasize to you how accuracy is important. Here is a lady who had this fracture and fixation. She landed up with RSD or, causalgia or CRPS2. She presented to me like this, and she just could not move her hand, total disability. She's a dietitian, very smart girl, and she just was not able to use that hand. And when she came to me, I started treating her for CRPS2. She recovered completely. She became all right. She went back to her normal life, but then she had an ulnar claw because of the CRPS2 part of it. So this girl, I'm stimulating here. She's
more in my ulnar and my middle finger.
What the patient is saying here is, I'm feeling it in radial and ulnar. I'll accept this. So she's telling you that she's feeling it in ulnar. You can see the claw there. And here I'm passing the catheter here. The catheter, The stimulation goes on and she continues to tell me that she is getting ulnar stimulation. Again, ulnar again. Do you want actually later in the catheter I am getting it. Excellent. Now radial is coming. So, what are you getting now?
I'm getting more on these three. In
Ulnar you did get in.
yeah, in between I got a very...
Yeah, no problem. That's good. So, thank you very much. I hope I have conveyed what I was supposed to.